First, thank you for having me today. I was really excited. And I'm hoping that I can talk a little bit, but maybe not talk the whole time. And maybe I'm going to save some time at the end to answer questions because it's about engagement. And so I'm hoping that we can engage and it's not just me talking at people. So thank you so much for having me. It was a great way to wake up. I checked my email on Thanksgiving morning because I am that person, and I got the notification that the article had been published, and I was like, "Oh, that's a nice way." I'm thankful. I'm thankful for my amazing collaborators and the participants who contributed to that paper. So it was a great way to start. I'm going to share my screen and then put it into presenter mode. So you may just have to tell me if you can see the right version or not.
Okay.
Then I don't know which one you can see. Can you see my view or the other one? Swap display. How about that? Which one?
I see, hold on, I see my screen. It's like giant on my screen. Let me zip it down. No, I think we're good.
Okay.
I can see it looks right.
Great. Okay. So I had thought that what might be helpful is I could talk about qualitative research, but I think more broadly, I thought it would be sort of fun and lead to an interesting discussion in talking about equity and engagement in implementation research. And I'll tell you a little bit about implementation research to get us started. But really sort of thinking through why engagement is important in research. I mean, we know it's important, but sort of why it's important and how both from the sort of researcher and funder side, as well as from the sort of participant community side, working together means that like the research is better. And then because the research is better, it is more likely to actually improve equity and make things better for everyone. So the impact of inequities in research, basically research results are often not representative of the population. It's sort of excluded participants from sort of the decision making. It's excluded participants or certain populations from sort of the sense making of it, the sort of, what does this mean? Why does this look this way? Like, why did we get the results we get? Why did it work for some people or not other people? Also, it has, doesn't reflect, we do all of this research, say, to help, pregnant people or postpartum people, but sometimes that research doesn't actually address the things that are of concern to those people. People know sort of what the gaps are in the care that they've received, or what the gaps are in the system that is providing resources to them. And we often don't ask the people who are experiencing the inequities sort of what is their most important problem. If someone's most important problem is that they don't have housing at the moment, sort of trying to get them to take a prenatal vitamin is maybe not going to be their top priority. So really thinking through with the populations we're trying to help, what things are most important to them so that we can sort of make sure that we're doing research that is going to meet people where they're at. And so because people sort of aren't involved from the beginning, like we don't have people involved in research from sort of the design of the research questions, people who are difficult to those sort of vulnerable populations, people who live in rural areas, people who don't have insurance, people who aren't coming into their clinic visits already, those people tend also not to be sort of involved in the research itself. They're not participants in the research. And so then the sort of outcomes tend to exacerbate the disparities. So I'm sure you've all heard, about how some of the research findings are like designed for like, your average 35-year-old white male. And so, like the things aren't relevant to like the entire rest of the population. So that's the sort of basic, concept here. And so, some of the groups that are historically underrepresented in research, there are other groups, but racial and ethnic minorities, people with disabilities, the LGBTQIA plus populations, people who are transient or unhoused, people who are justice system involved, socially isolated and disengaged are those people who either because of where they live or because of various social or mental health or personal issues aren't going to the doctor's visits already, aren't going to the healthcare, right? Like if we design a really amazing intervention to be delivered by a doctor, if they're not regularly going to the doctor, that's not going to be a great version. And then people in low resource settings generally who don't have transportation, who wouldn't know about the research. And so when you look at these groups of people, these are the groups of people who, when we try to do equity-based research, we want to help. They are experiencing the disparities, but if they are not research participants, then it is very hard to do research that addresses disparities if we don't even have data on these populations. So our research tends, if we're not thoughtful from the very beginning about how to engage people who are experiencing disparities, the research tends to exacerbate the disparities, even though we're doing disparities-focused research. So disparities are sort of well described, right? I think the report that I always go back to in sort of quality improvement implementation research is this Crossing the Quality Chasm report that came out from the Institute of Medicine saying, like, we know that there are these huge gaps in the care that are being delivered. That book came out in 2001, which in my brain doesn't sound like it was that long ago, but it was almost 25 years ago. So, so we know disparities exist. We all know they exist, but progress hasn't really been made. And so there are two major reasons for this. One, we all know that there are structural, multi-level structural pervasive barriers and biases and isms that exist across all of the settings at all levels of our society. And that's sort of the structural problem. But then if, like I said, if we don't think about intentionally including populations in all levels of research from the very beginning all the way to the sort of dissemination of how we're sharing the results, we are likely unintentionally contributing to the disparities by the research that we're doing. So I know I'm going through this super fast. I'm kind of just trying to set a big picture stage for the discussion. So how can implementation science, the work that I do, try and address some of these disparities? And so at the most basic level, implementation research is how do we get research findings into practice? So, right, like the latest research shows that we should do something with all the research. And I have this slide that I didn't put in, but based on sort of the analyses that implementation researchers have done, it takes approximately 17 years for like the results of a clinical trial to actually make their way into what is happening like at the bedside, at the clinic visit in the way that we are delivering care. Because the sort of idea was that we'll produce the research and then it sort of just by virtue of diffusion sort of makes its way into practice, and nobody really thought about it. It was just like, we'll produce the research and it will be taken up by people without really thinking about how that sort of translated from sort of clinical findings into practice. And so implementation research really thinks about how to implement evidence-based interventions or innovations or ways that we know are best practices, like say, for example, aspirin or whatever the thing may be, into actual practice. And why does this happen? I mean, right, like in order to produce, sort of like the evidence that a vaccine works or, a medication works or whatever to reduce blood pressure or whatever the thing is, right? We have to sort of control the environment to understand exactly if that intervention works or not. But when you then go into the real world, right, it's not controlled. It's the opposite of controlled. It's dynamic and complex and populated by people who are not predictable or rational or have all sorts of things going on in their lives that we couldn't possibly take into consideration when we're doing very controlled clinical or pharmaceutical research. And so implementation science is the scientific study of methods to promote the uptake of these research findings into routine healthcare in clinical, organizational, or policy contexts. And so it's not just sort of how doctors provide care or nurses provide care, or clinicians, or you get care. It's sort of also thinking about how organizations, healthcare systems, state departments of health, how they work together to make sure that these practices, these evidence-based practices are implemented, because we know it, and I'm sure that doctors on the call can tell you it's not just up to them to decide what they do, right? There are all sorts of other things that go into sort of like how they structure their time. And so it really has to be all of the people at all of the different levels of the system thinking through how to make sure that we are sort of doing what we know is best. And that's not just a personal choice, it's sort of a structural and systemic change that needs to be made in order to change practice and incorporate these evidence-based interventions. And so the way that implementation science does this is with these sort of 4 questions. And so it's like, okay, we have this research finding, right? This evidence-based practice and what's actually happening. So the first thing is to decide what needs to change. For example, people are not getting evidence-based mental health care, but we know there is evidence-based mental health care. So like, what is the gap, right? Then how are we going to, like, how is it going to happen? Why is it going to happen? Like, what is the sort of, how do we think, like, if we do this thing, it will make it better? What's our hypothesis? How will it occur? Then what are we going to do to make it occur? How will we create the change? Are we going to talk to people? Are we going to test different things? And then sort of the big difference, I think, between the sort of quality improvement and implementation research is not just doing the thing that you say you're going to do, but actually just looking to see if things actually changed at the end of it. Because in early sort of research, right, you can change stuff, but if you're not sort of addressing the actual barriers and you just did a thing, then it might not actually make anything better. So you kind of have to look at the data to see if the things that you're doing are making things better. And so the way that I think about incorporating equity into it is sort of, we're talking about these evidence-based interventions, but like, are they being adopted by different people for different reasons? So if there is a clinical intervention that is a decision support tool for providers, but it's not, it doesn't work for people who can't fill their prescription, say, or people for whom English isn't their first language, because the clinical decision support tool is designed to like send a prescription. It's designed to work in English, right? So if the clinical decision support tool is like a great option, but you have to understand who it's working for. Are certain providers more likely to use it? And so you really have to think about who's using the interventions, why they're using them, and if it looks different for different people. And so really, and I mean, I'm not going to read the slide, but really implementation research and thinking through equity is sort of understanding when we go to implement interventions, whether those are pharmaceutical interventions or behavioral interventions or clinical interventions, right? We're going to start treating a particular diagnosis a particular way. We really need to think through, right, how do we make the system change so that it makes it easier for the people delivering the intervention, whether that's a clinician or a community health worker or, a nurse practitioner, sort of how do we change the system to make it easier for the people delivering the intervention to deliver it? How do we make sure that the people delivering the intervention understand the intervention, believe that the intervention is effective? A lot of times there's doctors really like to know what the research is to say that this is the thing that they should be doing. And then once they do it, it's delivered by whomever, right? Is it working for some populations versus other populations? Does it work for rural populations as well as it works for urban populations? Or does it work for uninsured people as well as insured people? And so that's sort of where the equity comes in, right? If we are not including underrepresented groups in our research, then we're not going to necessarily know if the intervention works for that group or not, if they're not included as research participants in our research from the beginning. And so there's a lot of work done on engagement in research, but I just wanted to sort of put this up here because I think that, now that sort of funders require, the sort of participant engagement in some way, stakeholder engagement, they tend to favor that. Most people say like, okay, we're gonna like ask people what they thought, or, we're gonna make sure that that we survey people and say, did you like it or not like it? And that's the sort of feedback monitoring, that sort of light touch. Maybe you talk to people one time and ask them their opinion one time. There's partnerships, which I think are pretty straightforward, right? But it's more about collaboration and sort of sharing the tasks of the research. So maybe a community-based organization and an academic medical center, right, have partnerships. And then there are multi-stakeholder partnerships where maybe the funder and the a nonprofit or a non-governmental organization and a healthcare system. When we talked about and a state department of health or an insurer or whatever, right? When you have these sort of partnerships that involve all of those people in that spectrum to say, okay, how are we going to make this better for all of the people for whom it needs to be better? And then the social alliances, I mean, that's the like sort of magical ideal world where everybody works together in this sort of inclusive way. Everybody has like a commitment. I mean, that is the goal, and there are great examples of that. I'm sure we'll hear about some of them today. But I think that there is a big spectrum of how we can engage, and it's not that one is right or wrong. It's just that sort of thinking about the level at which you are trying to understand change. Maybe you're only trying to understand this one change in this one practice. And so you don't necessarily need to involve the federal government in understanding that. And sometimes when you're looking to make a big change in how sort of we fund care, then you need to think about having more stakeholders involved. And so I talked a little bit longer than I thought I was going to, but I just wanted to sort of open it up to talk about, I think people on the call have experiences being involved in research, and I bet everybody has ideas about it. And so I really thought that it would be great for me and hopefully great for everyone else to just have a conversation about how we might sort of facilitate that through this work together. And questions, if it wasn't clear, also questions, of course.
No, yeah, I actually do have one clarification question. When you talk about funders, can you talk a little bit more about the different types of funders that for our patient members?
Sure. So funders, there are two, I guess, buckets of funders, right? There are the people who fund the research. So like PCORI, like NIH, right? We submit research proposals or sort of different types of proposals to people who fund research. And depending on who that is, right? If it's the NIH, they have their own priorities. If it's like the Gates Foundation, if it is sometimes for the pharmaceutical companies, sometimes the Department of Defense funds research, right? Like thinking about those people who fund research are and their priorities and why they're choosing to fund the things that they're funding and how they work together with the people who they're funding is very important. And then there are the people who like actually pay for healthcare. And sometimes those are the same people and sometimes they're not, but they are also stakeholders. And sometimes research is the best way to convince them to fund some new thing because we've shown that it like makes things better for people. But they also have their own priorities, like if it's an insurer or Medicaid or Medicare, right? Like they want to know at a population level if it's going to make it better before they start to pay for it, say with your insurance. So that's kind of what I meant by fund. It was a sort of very loose term to talk about lots of different people.
And then when you talk about like insurance companies, yeah, they want to see that it works. They also want to oftentimes, I imagine, want to see if there's a reduction in cost because it works, right? This works, so it reduces their other costs over here. So they're willing to pay for this intervention because, it's helpful and also it's going to, reduce costs. And if it's helpful and reduce costs, hopefully that means it's reducing illness, in the present term and hopefully in the future as well.
Right. So I would just say implementation research now, as the field sort of develops, it's a reasonably new field. Most projects, big projects now have like a health economist on the team because they want to know ahead of time, like how much of a doctor's time did it take to do this? How much time did it take them in the visit? Like what did they not do? when they were doing this thing, right? Did we have to have nurses? Did we have to have administrators? Did we have to bill differently? And so they really want to understand the entire cost of the intervention, not just like how much the pharmaceutical costs, for example, right? But they also want to show like, okay, if like we reduced like people's blood pressure, and so then they like were at less risk for like serious health concerns in the future, right? Like then that's like a cost benefit analysis that are for people who do that. I am not smart in that way. But it is obviously very important. But to anybody, like healthcare systems too, right? Like they don't want to ask their people to be doing a thing if they don't know if it's going to benefit their populations.
You said that implementation science is a relatively new field. Like, how long are we talking here? Like,
20 years-ish.
yeah, that's new in the.
Yeah, it's I think about sort of 15, 20 years, I would say.
What drew you to implementation science?
What drew me to implementation science? So before I came to the University of Iowa, I worked at a hospital in the Bronx in New York. And I was the associate director of quality for the hospital, where we monitored everything from like adverse events in the emergency department to like people were, had falls. Someone fell while they were an inpatient, or if there were surgical errors, or, we monitored everything. And I think that, there was ways to think about equity in that work, but really it was smaller scale. And for me, I wanted to think bigger about how the changes that we make in healthcare, how we can think about that at a sort of broader level, not just more people, but with more stakeholders, and thinking about context, because, right, an intervention that's developed in the United States is not going to work in Tanzania, right? And so really, but that also means like an intervention designed for white men isn't going to work for like Black women, so I think that those were the things that sort of the ways that implementation science helps me ask those types of questions, and then feed the information back to people. So the research that I do tends to be stakeholder driven. So people come to me and say, we have a question, right? And we need help answering the question. I don't come up with the question, so I don't come up with the problem. My current, my big research project is working with home visiting programs for pregnant people in Iowa and Indiana, implementing a mental health intervention into home visiting programs. And the reason that we're doing that is because the Iowa Department of Health and Human Services came to us and said, our home visitors need training in mental health, right? Like they are seeing increases in mental health issues with the people who they visit, right? The people. And so can you help us figure out how to implement an intervention for home visitors in a way that is equitable and sustainable and efficient and cost effective? So that's the work that we're doing right now. I didn't go to the State Department of Health and say, you should train your home visitors in this intervention. So I think that it's really sort of thinking through how to work with people to help them solve their problems or answer their questions or think through things in a slightly different way.
And I'm really glad to hear that they thought about mental health and also asked the question, so you could help answer that question, or at least lead them in a direction. Because how do you walk into somebody's home and handle a bunch of things and sort of disregard, the elephant in the room, there's a mental health component. Obviously, mental health is a hot topic here in our group. We have, probably 85% of our population anecdotally. If they didn't have a mood disorder walking into traumatic pregnancy or birth, they've got one walking out. And so, I'm always happy to hear about mental health intervention. So thank you for helping them work on answering that question. And I'm excited to hear more at some time in the future about how that goes. So, because that could be something that could be replicated elsewhere. And of course, Indiana and Iowa has a lot of rural population. So let's see. I don't know if anyone else had, there might be a question. Oh, nope. So you mentioned we don't ask questions of the patients who are experiencing the gaps. And yet one of your slides kind of said, okay, we're doing a better job of that now. And I know some of the funders are, asking for patient input as part of, paying for research. So
Mhm.
that's good. I mean, there are some maybe obvious reasons why we don't ask, or why we haven't in the past asked patients about gaps. Maybe we just didn't think that there were gaps, because the people that need to ask the questions had a hard time seeing beyond their own,
Mhm.
what else? What else? Why else are we not asked or have?
Um, I mean, that is a semester long question.
Yeah,
So I
yeah.
can't, I mean, like, so I think there are historical reasons for it, in the sort of history of medicine. It tended to be more sort of hierarchical, where the doctor was the authority and the patient was just the recipient. And healthcare has changed now that there's much more of a partnership. And so in the changing the way that healthcare is delivered, we've sort of changed the way of how that interaction works. And so it's moving in the direction of more of a partnership in just the sort of clinical interaction, which is change. I also think that it's really not straightforward to engage some of these populations in research, right? Like if they're temporarily unhoused or they're incarcerated, it's very how do you even get to them, explain to them the research, right? Like they have other stuff going, like they shouldn't be like it is not
Right.
their priority to be like, let me tell you what I think about healthcare, you know? So, I mean, I think that there are lots of structural things, not just like we didn't want to know. I think that there are a lot of structural barriers to asking people. And even when you think about like a community advisory board or a patient advisory board in a hospital, those tend to be people who have extra time, who can like take time off of work, or have transportation, or have the ability to sit on a Zoom for an hour and contribute, right? Like those are not unhoused people. Those are not people who don't speak English, right? Like so even in the ways that we are starting to do it, there are still structural barriers that stop us from reaching the populations who are probably the most vulnerable and experiencing the most severe disparities, which is not anybody's fault, right? It's just like we're taking steps, and it's going in the right direction.
Yeah. I've done a good amount of work with perinatal quality collaboratives around the country. And I find that even they have a difficult time, and they have patient advocates, they have patient advisors, like they're like, please come and please, sit through our meetings, and they have a really hard time engaging us. And I've tried to like give them ideas, like here's some ways that I can help you. Here's some things here's some questions you could ask. Here's some ways we can be involved. And it seems really even still, challenging to get those folks who clearly are trying to implement change, right? Because most of that time is voluntary, and it's an additional full-time job on top of their other clinical requirements. But even they have a hard time, I think, figuring out how to engage with patients, even when we're like, I'm a patient advisor, I didn't have service in your hospital, I'm not going to sue you. Um, I'm here to help. I'm here to improve. And I would encourage everyone who is interested in that sort of change to get involved. If you have a state perinatal quality collaborative, it's a good way for patient members to volunteer and participate. Thank you so much. I appreciate you. I